Hi everybody, this is the highest yield. Before we actually get into the nitty-gritty of the ECG, let's talk about the architecture of the heart. This is a vast oversimplification, but for our purposes, there are three types of cells in the heart. One, the pacemaker cells, labeled the SA node and the AV node here on the diagram, create electricity spontaneously. Two, there are specialized conducting cells, labeled the internodal pathways, the bundle of His, the left and right bundle branch, and finally three, the muscle cells, all the red tissue that houses everything, those contract. The second important thing to note is when all this electricity pulses through the heart contracts in this order: the top, called the atria, and then the bottom, called the ventricles, and then relaxation. Now, the connection between electricity and the myocardiocytes is that the muscle cells contract when exposed to electricity, but don't sweat the small stuff. We said that the atria contract first, then the ventricles. This is because the current of electricity usually starts at the top of the heart at the sinus node and then will flow downward and slightly leftwards toward the ventricles. All the electricity flowing through the heart at a moment in time can be averaged and goes down and to the left. This is called the mean electrical axis. Let's start talking about the actual ECG. To understand the ECG, remember that the mean electrical axis, or the mean electrical current, travels through the heart in a downward and leftward fashion. If we stick detectors, called leads, on various parts of the body surrounding the heart, like the arms, or our legs, or the front of our chest, we can kind of create a three-dimensional understanding of the mean electrical axis and how it moves. And this is crucially important to understand. If the mean electrical axis is moving towards a detector or lead, it'll reflect on that lead as a positive signal. If the mean electrical axis is moving away from a lead, it'll reflect on that lead as a negative signal. Additionally, the more the mean electrical axis is aligned or misaligned with that lead, the greater the magnitude of that positive or negative signal. There are 6 limb leads which exist on the coronal or frontal plane. There are 6 precordial leads which exist on the transverse plane. What matters is the direction that these leads or detectors pick up on, and this, unfortunately, just needs to be memorized. Inferior leads are 2, 3, AVF. Left lateral leads are 1, AVL, V5, V6, and anterior leads are V2, V3, V4. Right-sided leads are V1, AVR. Note the position of these leads on the diagram. The arrangement of these leads on an ECG sheet is like this. Translation from the electrical current to the contraction of the heart to the ECG. We know that the current starts at the sinus node, located at the top of the heart, and starts moving downwards and slightly leftwards, causing the atria to contract, and then the ventricles, and then relaxation of the whole heart. This can be translated into the P wave, atrial contraction, QRS complex, representing ventricular contraction, and T wave, which represents repolarization. Note that this particular P, QRS, T configuration is usually seen on lead 2. Other leads vary based on how closely the lead aligns with the mean electrical axis. Armed with that knowledge, we kind of understand how the ECG works now. This serves 2 purposes. 1, to make you feel like less of a fraud, and 2, this sets the stage for more difficult rhythms, like when pacemakers come into play, when thinking about axis and hypertrophy and all that stuff. But that actually doesn't really matter for 90% of ECG reading you do on a regular basis, which is mostly just pattern recognition. Let's work through on how to read an actual ECG. Apply these 6 steps to every ECG you see: rate, rhythm, axis, ST/T wave changes, QTC interval, and morphology. Step 1. Rate. On any lead, look at any QRS. Look at the subsequent QRS. Look at the space in between those QRS. Count the number of big squares between the QRS, specifically the tallest part of the QRS, the R wave. Take 300 and divide by this number. Tachycardia is over 100 beats per minute. Bradycardia, under 60 beats per minute. For example, the topmost ECG strip has 2 spaces in between the QRS complexes. 300 divided by 2 is 150 beats per minute. The second strip down has a rate of roughly 280 beats per minute. I did this by taking 300 and dividing by 1.2 squares roughly. The third down, roughly 30 beats per minute. 300 divided by 10. Note that this fast method only works if the rhythm is regular. If irregular, like in the bottom example, or just as an alternative method, you need a rhythm strip. The long strip found at the bottom of an ECG, usually displaying V1 or lead 2. Count the number of QRS complexes and multiply by 6. This rhythm strip for lead 2 has 27 QRS complexes spanning the page. 27 divided by 6 is 163 beats per minute. Step 2. Rhythm. This is easy. Is the space between the R waves relatively constant? From the top, we have an irregular rhythm, then regular, then irregular, and then regular. Step 3. Axis. This is also easy because we're going to ignore it. In the context of a busy ER, you generally do not need axis to diagnose things like heart attacks and atrial fibrillation. ECG axis changes can play a role in diagnosing things like pulmonary embolism, but even then, there are more useful metrics. This is the big one. Being able to determine where an MI has occurred in the context of an acute coronary syndrome is useful. If you see an elevation of more than one little square in any ST segment, conservatively speaking, this is concerning for an ST elevation myocardial infarction in the right context. Context prototypically being crushing chest pain radiating down my arm and up my jaw and being sweaty and nauseous. The location of the ST elevation corresponds roughly with the part of the heart that's being affected. The inferior leads correspond to the right coronary, the left lateral leads correspond to the circumflex, the anterior leads, in this case including V1, because recall that V1 is technically a right-sided lead, indicate the left anterior descending. On a side note, T-wave inversion is concerning for non-specific ischemia, but in V1 and AVR is usually normal. This is likely an LAD/anterior STEMI. This is likely a circumflex or lateral STEMI. This is likely an RCA or inferior STEMI. Regarding the QT and QTC, the QT changes depending on the heart rate. Therefore, the QTC estimates QT at 60 beats per minute, kind of like a weird standardization. Long QT predisposes to torsade de pointe, which is characterized by wide and bizarre and inconsistent QRS complex, and is actually quite pretty. Calculate QTC via this nifty formula from our friend Bazette. Note that one tiny horizontal square in the ECG is 0.04 milliseconds. Count the tiny squares in the QT interval and count the tiny squares from one R wave to the next and insert into the formula. A concerning QT is over 450 milliseconds on average, technically 440 for males and 460 for females. Important knowledge to have is that hypomagnesium, hypopotassium, and hypocalcium can cause prolonged QT. Also, 6 important drugs that prolong QT: antipsychotics, SSRIs, amiodarone, macrolide antibiotics, ondansetron, and diphenhydramine, which is the active ingredient in Benadryl and Gravol. These drugs are also known as the antis: antipsychotics, antidepressants, antiarrhythmics, antibiotics, and antiemetics. Let's finish off with some ECG findings that even if you knew none of the knowledge above, you should still be able to identify. Atrial fibrillation is the first one at the top, and it predisposes to stroke. This is bad. The second one down, ventricular tachycardia, predisposes to death. This is also generally bad. Ventricular fibrillation, the last one at the bottom, is imminently lethal, and the latter two need immediate cardioversion. AFib is actually relatively common. Bundle branch blocks are pretty neat. The right bundle on top will present with this wide RSR prime pattern in V1 or V2, colloquially called bunny ears. The left bundle on the bottom presents with this wide R wave in V5 or V6 and huge and wide Q waves, downward reflections in the anterior leads. RBBBs can be benign, but new LBBBs can indicate ischemia and warrant more detective work or investigation. This is a normal ECG. Remember to practice so you can look as cool as possible when they hand you that pink sheet.
Thanks, everyone. This has been the highest yoga.